I feel like I have more double chins in this video than usual, but well, struggle's real. Little kids, especially when they are sick, are scary. They're scary because one, who wants to have a sick little kid? Nobody. And two, you need to take care of lots of sick kids to be really proficient at it. Luckily, kids are pretty easy to take care of, even when they're dying. Focus on the basics. The basics will not fail you. Tip one is to use the pediatric assessment triangle. You could chase all the lab values, vital signs, ABGs, VBGs, end tidal, but at the end of the day, what really matters for you are these three things. If these are good for the time being, the kid is good, and you could take a deep breath and relax your asshole a little bit. Two, take the onesie off or lift up the kid's shirt. Kids are deceptive little buggers. They may be looking like they are resting comfortably, and they may look completely comfortable, and then you unzip that onesie or you lift up their cute little shirt, and you see ugly retractions or seesaw breathing or belly breathing. You've got to expose the kid and actually look at their body. Three, hypoxia is bad. Very bad. In fact, it's the worst thing that can happen to a little kid. Everyone has probably heard 5,000 times that hypoxia is the number one cause of cardiac arrest in the pediatric patient. It cannot be emphasized enough that little kids do not tolerate hypoxia. Again, little kids do not tolerate hypoxia. The pediatric patient doesn't have the same functional residual capacity of the lungs that the adult does. The oxygen that the kid breathes in is the oxygen that they use, even when they're healthy. They are immediately affected by hypoxia, and they will precipitously get worse unless you correct the hypoxia rapidly. And this brings me to my next point. Pulse ox is the most important respiratory monitoring tool that we use in the sick kid. We want to avoid hypoxia like the plague. Well, what about the end tidal? Well, I won't go as far to say that a non-invasive end tidal CO2 reading is useless in the pediatric patient, but while kids do not tolerate hypoxia, they tolerate hypercarbia extremely well, like little champions. As long as the pulse ox is good, I really don't care what their end tidal CO2 value is, because hypoxia is what's going to kill them, not hypercarbia. In fact, the kid's work of breathing and their pulse ox readings should be your primary decision makers. You should not be making treatment decisions or the decision to manage a kid's airway based off of an end tidal CO2. And for you critical care transport people out there, same thing goes with an ABG. An ABG in a kid is of extremely limited value. It is only a measure of the blood gas at that exact moment when the value is drawn. Kids are super dynamic, and their ABG or VBG may be completely different 5 minutes later than what it was when the blood was drawn. So do not get analysis paralysis. Focus on the pulse ox and the work of breathing. Now, I know there are going to be some people out there who are starting to get fired up and getting ready to send an angry email or light me up on the comments. Check out these resources before you waste your time. 5, take a freaking blood pressure. I don't know why this is a uniquely EMS thing. Oh, we don't need to take a blood pressure in the pediatric patient. You absolutely do. And I would know the minimum systolic blood pressure for a pediatric patient. 6, check a blood glucose on all sick or seriously injured pediatric patients, even if they aren't a diabetic. Kids have limited glycogen stores in their liver. They burn up glucose rapidly when they have to compensate for acidosis, bleeding, dyspnea, etc., etc. They definitely can, and I've seen it, become hypoglycemic after seizing, burning up all of their energy trying to compensate, or they have a high fever and they're in metabolic overdrive. Check the blood glucose. 7, give fluid if you think they need it. And if they're sick, they probably do. The sick kid is going to be profoundly dehydrated. Even if they don't look it or the history doesn't really support dehydration, they're going to be dehydrated, especially if they're short of breath or tachypnic. What do sick kids do to compensate? They pick up their respiratory rate. They expire moisture when they breathe out. And if you do this 40 times or more a minute, you're putting out a lot of moisture from the body. So kids get really dehydrated and they don't show signs of it until it's too late. And then of course you add normal sick kid stuff like nausea, vomiting, diarrhea, irritability, decreased fluid or food intake, and that can lead to serious dehydration. A 20 milliliter per kilogram bolus in these kids can work absolute wonders. 8, And this will piss some people off too. A pre-hospital 12-lead EKG is of extremely limited value. Again, I can hear the gasps and angry fingers revving up to comment. The reality is that kids don't have STEMIs. I'm sure there's one or two freak cases out there that you can find in the literature. There's always one in every crowd. But in general, they just don't happen. Kids get myocarditis and pericarditis. In the pediatric 12-lead EKG, anything can be a sign of anything. Unless you're a pediatric cardiologist who's reading these things all the time, then you're not going to get that much value out of them. Again, I'm not saying to not do them, but I'm just keeping it real here. Also, the pediatric heart is constantly in transition, and there are going to be changes in some kids. What is a normal EKG in a 2-year-old could be a abnormal EKG in an 8-year-old. 9. Croup is scary, but is generally not a big deal. More gasps from the crowd. They look really sick and they can sound really sick and their breathing can look and sound terrible. But unless they have some congenital problem or some sort of chronic illness or disability, kids with croup actually do extremely well. Even in children with severe tracheal stenosis, less than 1% of these croup kids need to be intubated. And of those kids who need to be intubated, again, virtually all of them do fine, barring some other chronic condition. You treat these kids with steroids, Decadron, you give the IV preparation orally. Yes, you heard that right. Then they get nebulized epinephrine or racemic epinephrine. Yes, it has been classically taught that racemic epinephrine will cause less cardiac side effects. Depending on which source you read, this may not be totally true. The difference is, and this is total nerd shit, but racemic epinephrine contains 2 types of epinephrine, L and D epinephrine. You're only getting L epinephrine in traditional epinephrine 1 to 1000. As far as the cardiac side effects, super rare. Don't withhold epinephrine in a croup kid because you're worried about tachycardia. Real world, you're probably not going to see it. And as the kid gets better and as they feel better and as their breathing improves, you're probably going to see the heart rate actually start to go down. 10. Use a checklist. It's simple crew resource management stuff. Remember, we don't treat lots of kids, and we definitely don't treat lots of critically sick or injured kids. So use a reference. It keeps you in check, and it helps to eliminate those human factors that make us innocently and naturally do stupid stuff. Trust me, whether it's Braslo or whether it's Hantevi or some other company or a checklist that your agency or jurisdiction made, use it. You will be much more effective. It will take the mental med math and the thinking out of the equation. It will help you deliver better care much more efficiently to your patient and mitigate the chance of you fucking something up. And those are my 10 points for managing the sick pediatric patient. Let me know if you have any questions or comments, and thank you for letting me share.